Thanks and welcome everyone for the webinar today on how to deliver safe and effective agentic health interventions. Just from my side, I have a double affiliation with, since 16 days, the Center of Digital Health Interventions with Tobias, and also the Psychiatric University Hospital in Zurich. And for the content today, probably you have seen it online on LinkedIn. So we cover quite a lot of content, and just to give a bit of an overview of what is out there. It's still a lot of position papers, about a lot of opinions, and I just try to kind of make a bit of sense of it. So I hope to give you a nice overview on what is out there. So with that, I just directly start from rule-based towards agentic digital therapeutics. So for a long time, digital therapeutics were mostly rule-based systems. As you can see here, on the video here, this is Max, a digital health literacy coach for children with asthma. And whoever is following some webinars of Tobias has for sure already seen that. So these kind of systems, they follow a predefined flow, predefined content, and of course also predefined safety mechanisms. What we're seeing now, however, is kind of a real shift. So we're moving away from these rule-based digital therapeutics towards more agentic systems. As you can see here in the video, you have the subtitles, but not the voice. But this little race humanoid is talking to the user. And these systems, they use LLMs to hold conversations, and they can adapt responses, and with that also engage users more naturally. So, but with that change or that shift changes not only how the systems behave, but more importantly, they also change how they can actually fail. So in rule-based digital therapeutics, safety could largely be encoded into flows and constraints. Now in agentic digital therapeutics, safety can no longer only live in the rules, but it has to really be implemented in the system design. So that's also why questions around working alliance, risk detection, clinical boundaries, and also data handling now become kind of a first order safety question, and it's not only an add-on. So in these sessions, I'll focus a bit on what this shift actually means in practice, also due to my background, a bit more especially for mental health, and also how we can think about safety in a more structured way as the systems themselves become more autonomous. So let's start with the evidence reality. So as of today, there is a lot of new research out on digital therapeutics, but often we know that they produce clinical outcomes, but the mediators and moderators of effectiveness still remain largely unexplored. So that means we know that some interventions, they work, but we don't necessarily know why or for whom also. Also, most of the studies nowadays, they actually lack follow-up data beyond 6 months. So that also means that they might have short-term benefits that may not translate into lasting changes. Moreover, also, there's also insufficient evidence across diverse cultural, linguistic, and also clinical subgroups. That means also results are not necessarily generalizable, and this also limits results or limits the findings. So then further, we of course have also some safety gaps. What has also been observed is that current agents often they fail in crisis scenarios, such as when subjects have a suicidal crisis or similar. So that means that this real-world deployment of agentic systems could actually even risk patient harms. So in summary, if mechanisms, long-term outcomes, and safety boundaries remain unclear, the question here becomes how do we regulate and deploy these systems responsibly today? So roughly 1 year after the first release of ChatGPT, this paper here by Steven Gilbert and his colleagues already identified LLM's potential, but also its danger or its risks for healthcare use. And they also claimed already in 2023 that LLM AI chatbot should actually fall under medical device regulation. And also a recent commentary here from the same group in MPJ Digital Medicine makes a very pragmatic argument here. So they say if a system consistently behaves like a therapist, is it like in language, structure, also the guidance they provide, then from a safety perspective, it is or it should be a medical device. So also that's actually the title of the paper, which is extremely catchy. So like if a therapy bot walks like a dog and talks like a dog, then it is a medically regulated dog. And so once we kind of accept that, disclaimers are not longer sufficient. So it's not enough to just say like, oh, by the way, you're talking to an AI chatbot, just that you're aware of that. So that means safety should actually be designed, evaluated, and enforced, and not only like assumed in the form of a disclaimer, for example. So in the next few slides, I would like to also give you like a quick overview on like current opinions and how also this issue should be like targeted. And overall, this kind of leads to kind of a layered evaluation approach. So you will also see like what that means, but in a way like separating what a system can do, what it should know, and how it should reason. So I like to show you two different approaches, but the first approach is on benchmarking LLMs for the use in mental health or like medicine in general. And that was done by Huang and colleagues. And here they benchmarked 16 mainstream LLMs. That was back in 2024 with or using like over 30 data sets. So what they call here trust LLM formalizes trust as like a multidimensional system property and not like just a single metric. So they first performed like a very thorough literature review to kind of identify what are the core principles for benchmarking LLMs for what they call trustworthiness. So, and this is a mostly prompt-based approach, and they define potential like benchmarks to evaluate trustworthiness based on these different core principles that they identified. And they also provide detailed instructions within their paper that is actually over like 100 pages long. So it's like really, really great to read. They provide the instructions on how also to prompt and to test the behavior of LLMs with like specific questions. And together, they decompose trust into like these 8 technical dimensions. So just to make like a simple example, for example, on privacy. So when you, for example, use a data set that contains a structure of like personal information, they were then prompting the model in a way that they wanted to break the privacy awareness so that it leads somehow to a privacy leakage. So for example, it was like clearly instructed not to release any private information, but they tried that like sooner or later, the LLM at some point would spit out, for example, phone numbers, email addresses, or whatever it found in the data set. So now, while these first 6 principles here can actually be tested using like existing data sets together with a set of highly elaborated prompts, the concept of transparency is mostly given actually by the LLM provider, while accountability should be provided by the digital therapeutics developer. So in a sense that first, the model should be released transparently with its weights and training data all well documented. But the accountability goes to the digital therapeutics developer, like in a sense that they must have certain guardrails in place on what happens when, for example, the LLM fails. So now we have like trust LLM. It sounds all very, very elaborated. And at this point, it's kind of tempting to say if a model is like safe according to benchmarks like trust LLM, then we're done. But trust LLM itself evaluates actually the system behavior, but not something that we can call relational trust. So mental health, but also other clinical fields where digital therapeutics could come at hand require actually this so-called relational trust. So for example, here when we talk about crisis management or also longitudinal care or even for diagnostic interviewing. So that means actually that a system can be LLM trust safe. So that means like it refuses unsafe requests or it avoids hallucinations. protects privacy and so on. But it's still clinically harmful. So the reason is that clinical harm actually rarely comes from like one single output, and it's more like a pattern of interactions. So like across time, context, and so on. So on this overall shows that like current LLM safety thinking is actually incomplete like for medical use, because it really ignores like this relational and contextual trust. So if agentic digital therapeutics are going to act like a clinician, then like trust must also be designed accordingly. And another approach here that is kind of like helping with that issue is this so-called tripartite evaluation approach that addresses this by separating it into three different questions that we need to answer. So first, the technical layer here is, so here it asks like, is this system deployable in healthcare at all? So we test like robustness, adversarial behavior, hallucinations. So this kind of, or this like kind of the failures that Trust LLM was very good at detecting. And it kind of validates Trust LLM and does not dismiss it in a way. So it's like basically what has already a bit been described in Trust LLM. But then second, we ask whether the system actually knows what it needs to know, so clinically. So this is the healthcare knowledge layer. So that includes like factual accuracy, but also whether it handles crisis-related content appropriately. So this is also actually where generic LLM safety often started to break down. And third, and this is also what the authors here describe as the hardest part, is to evaluate clinical reasoning. So does the system respond consistently across like complex and ambiguous situations? So does it escalate when it should, and does it stay within the scope when it shouldn't? So these are not properties that actually you can measure with isolated prompts, and they also like required structural vignette, expert judgment, and longitudinal testing. So we have here some key activities that should be done when using this tripartite approach. So like for technical safety, I think that's like pretty clear. That was also within the Trust LLM. But for example, for clinical knowledge checks, we really still should like validate against expert benchmarks and against clinical guidelines. And also here for the clinical reasoning, we should also provide it with like very complex vignettes or like situations that really require appropriate clinical judgment, and not just like, for example, one sentence and we say like, okay, based on this sentence, say if there is a risk or not. So yeah, in summary, such a kind of a layered tripartite approach, it does not replace like technical safety benchmarks, but in a way it completes them on a like more clinical level. So tools like Trust LLM tell us whether a system behaves safe in general, whereas the tripartite approach tells us whether it behaves safe as a clinician. And one use case here, and this is like probably one of the most critical one, is for example in the field of suicide prevention. So suicide is still like one of the leading causes for premature mortality, claiming almost up to 800,000 lives each year. And on the other side is like more and more people actually even turn to AI chatbots, even like general purpose models such as ChatGPT, or psychological support. However, these general purpose chatbots, they often provided unsafe guidance or even like fail to recognize acute suicidal intent, which highlights like a critical vulnerability, which is that most LLMs are not actually designed or validated for like detection and management of acute psychological crisis. So here we have also like transparency reports from like big companies such as OpenAI or Anthropic that indicated that approximately around 0.15% of weekly interactions with commercial chatbots actually contain the signs of suicidal planning, which is a proportion that is like way too large actually just to ignore. So one issue here is that commercial chatbots are actually optimized for conversational flow and engagement, which can actually mask these subtle warning signs, such as like any mention of suicidal intent, for example. So on top of that, they often also have overly protective guardrails, which cause the system to terminate a conversation abruptly, sometimes like issuing generic hotline instructions, when like someone mentions any sort of crisis-related content. But these kind of disconnections, while they are maybe legally good for the company itself, they conflict very much with like the well-established principles of crisis intervention, which is like to sustain engagement with a subject that is in a crisis. So because if you leave a vulnerable subject that has already expressed distress completely alone, like therapeutically speaking, this is extremely bad. So, however, there is, of course, extensive work already going on, especially in the field of suicide prevention, focusing also on the integration here of large language models. So, however, one issue is also that unlike structured clinical data sets, like that come from, for example, from clinical notes and so on, the crisis-relevant language often emerges more unpredictably, and it does not really follow like a predefined structure. And structured data is actually what would be kind of required to train classifiers reliably. So as a result, most prior work on suicide risk classification actually relied on synthetic data, post hoc annotation, or like this highly curated scenario, which highly limits also the real world application. So on top of that, even trained clinicians themselves are often not in complete agreement on whether or not a conversational snippet actually shows risk for suicidal intent. So all these limitations on suicide risk detection highlight that we kind of need to reassess also how we tackle suicide prevention in the age of LLMs and AI. So this disagreement, to start with, it does not reflect actually an annotation noise. It's more like an irreducible epistemic uncertainty, which implies that crisis detection cannot be treated as a conventional supervised classification problem with like clear decision boundaries, like crisis, yes or no. Because, for example, a person that expresses suicidal ideation is not necessarily at risk for a suicide attempt. So it's like, it's not easy to say where we actually put the decision boundary for when a person is actually at risk. So, and these limitations help also to explain why existing AI-based risk classifiers, even when they're like technically extremely sophisticated, so far struggled to be translated into a safe real-world deployment. So here also like optimizing models for offline accuracy or like aggregating performance metrics does not really resolve this fundamental challenge of acting under this uncertainty like in a live conversation. So so in practice, the critical question here is now not whether suicide risk can be perfectly classified, but whether the emerging danger can actually be detected early enough to enable this timely support. So in a way, this also reframes crisis detection in mental health chatbots from an accuracy-oriented prediction task towards something that is more like online and safety-oriented monitoring problem. So in other words, like rather than just inferring like on a single correct label, systems must continuously balance false negatives and false positives in real time. So kind of prioritizing safety while tolerating this uncertainty. And this seems like super hard. So that's why I want to show you also a bit like what we did here to work on that. And this is some work and some data from a collaboration of the Psychiatric University Hospital with Sonia AI, which is a startup from 3 ETH students. Currently, they're located in the US, in San Francisco. So the app itself is not available in Switzerland, but you could also just email them and they give you a research code if you're interested. But Sonia itself is an AI-based chatbot that provides like CBT-based kind of therapy. It's still classified as a wellness product, but it's a really cool app. And in the US, especially, like a lot of people are using that already. But what we did together with Sonia is like we elaborated on 3 different claims. So the first claim, as I already tried to explain here, is that suicide risk detection is inherently uncertain as there is no clear ground truth. And on top of that, we thought, okay, maybe the errors cannot be completely eliminated, but maybe we can tune the sensitivity with how errors are handled or detected. And lastly, as also mentioned before, is that safety is not necessarily a classification task. So we try here to move away from accuracy-based performance metrics towards more this uncertainty-aware approaches. So how did we do it? So we started with like a committee kind of clinical experts, and we asked them to describe like how they usually do like crisis detection. So what is happening in their mind when they talk to a patient and they try to evaluate if somebody might be at risk. So we asked them kind of to provide us with kind of their mental model also so that we could like write some guidelines, but in the form of how an LLM would understand them. So it's more like prompt based. And we then further had like a data set curated, which are real conversations of users of the Sonia chatbot. And we have there, I think it's like the last 10 like conversation or the last 10 messages of the dialogue before kind of an escalation was triggered. So before like the general purpose LLMs were thinking like, okay, this might be a risk factor or a risk case. We then asked our clinicians to rate those conversation snippets for like whether or not they think the subject was at high risk or not. What we then did here is some sort of LLM training, and I put it like in this, I put it as training because it's not really a training in the real sense. So we did not do any fine tuning or anything because we just worked mostly prompt based here. So what we did is we wanted to, like in line with our claim 2, we wanted to look on how we can maybe tune an LLM, like using prompts, so that it has different sensitivity levels on how it classifies risk. So for that, we had 2 different constraints. So first is the scope of covered risk. So like risk category definitions and also the triggering conditions were expanded like in a nested manner across different model variants. So we had like extreme low to extreme high sensitivity. So that means for extreme low, it only required it really required like the explicit suicidal intent, plan, access to means, and so on. Whereas for higher sensitivity model, we included like additionally a lot of other like risk factors and like broader cues also of like psychological danger. Second, we included also this uncertainty policy. So model prompts, they differed here also in the level of certainty that were required before actually classifying something as high risk. So that means like, for example, the low sensitivity variant really required a very clear and unambiguous evidence. And it was really told like, do not escalate unless it's like 100% unambiguous. Whereas the high sensitivity models or prompt variants required only like light indication of danger or like small signs of risk and like better escalate than ignore kind of style. So we then ask we use these 5 different prompt variants to also rate individually the same data set that the clinicians did. So in summary, like these prompt variants, they actually only differed through natural language instructions, but their behavior in a way should then empirically resemble like a thresholded classifier. So, and here are some results across these predefined sensitivity configurations. And on the left here, you see the receiver operating curve comparing like these 5 sensitivity levels. So Across this configuration, the model actually achieved an area under the curve of 90%, which indicates like strong overall discrimination between high and low risk cases. But the key point here is actually not the area under the curve. It's more that like each point corresponds to a different operational choice. And this already also translates here into the second figure. So on the right, we explicitly show how like false negatives and false positives behave as sensitivity increases. So as we move from a low to high sensitivity prompt, here the false negatives, they drop sharply. Where also at extreme high sensitivity, the false negative rate actually reached 0. So that means that like all high-risk cases in this data set were detected. On the other side, however, this came at the cost of like higher false positive rates. So more alerts for cases that were not truly a high risk. So in summary, this kind of illustrates the central design trade-off in safety critical risk detection. So we cannot fully eliminate errors, but we can choose actually which errors we are willing to tolerate. So that means that like a safety-oriented approach is like this trade-off between minimizing the false negatives on the cost of tolerating false positives. But like in suicide prevention, for example, prioritizing sensitivity here means like really minimizing the missed emergency, even if then increases the numbers of false alarms. But those false alarms then actually can be handled in a downstream mechanisms, which I also show you later. And also on this slide here, we looked actually at where the errors occurred and not only like how many. So on the x-axis here, we grouped errors by how many clinicians disagreed with the majority label. So 0 here means that like full agreement among the expert, and 2 means that there was like a substantial agreement. So across all the sensitivity configuration, we saw a bit the same pattern, which is misclassification actually concentrated in cases where clinicians themselves actually disagreed. And this really, again, suggests that the errors reflect like this underlying uncertainty in the task, and it's not a systematic model failure, so which actually supports our two claims. So first of all, when experts disagree, like a single correct label here becomes in a way ill-defined. So that's why safety here cannot mean to completely eliminate errors, but it means that making uncertainty visible and like calibrating sensitivity and like designing the escalation around it. So, and now how does this research actually fall into this tripartite approach that we discussed previously? And let me just show you a bit. So in summary, like the technical profile layer, like especially now for Sonia, has been long evaluated before this project was developed. So also like with reference to trust LLM and so on. But what we actually did, or how did we actually adhere like to this clinical knowledge checks and the clinical reasoning tests? So first, we carefully developed a prompt that was based on clinician feedback, and we tested it under different sensitivity constraints. So we actually did this validation of like expert benchmarks, or we did discuss it with the experts, and we did discuss clinical guidelines. So yeah, we could actually indeed show that crisis management was like technically feasible, as like this clinician knowledge was really like appropriately integrated into the system prompts. So second, we could then also approximate the clinical reasoning of the model, like given these designed prompts, by showing also that risk assessment is really a task that is inherently uncertain. And we could show that really model errors align closely with cases of clinician disagreement. So this also indicates that misclassification predominantly reflects this irreducible uncertainty rather than the model failure. So, and as promised, like how does this actually translate into the real world application? And here this slide brings a bit together all the three claims together that we have built towards. So first, again, suicide risk detection is inherently uncertain. Second, errors can be eliminated, but sensitivity can be calibrated. And third, safety is not a classification task. It's an uncertainty-aware process. So what's critical in the real-world deployment is kind of a separation of different roles. Like on the left here, we have the actual conversational model. So whose job it is to maintain empathy, coherence, and engagement. But in parallel, and importantly, it's like invisible to the user, is like this background safety system, which continuously evaluates risk. So this safety monitoring actually happens continuously without turning every interaction into like a crisis interaction. So each churn is then evaluated across the predefined sensitivity level, and this can, for example, be tuned based on the user. For example, let's say in like mental health, you maybe choose a higher sensitivity, whereas in like, I don't know, maybe diabetes care, you can go lower. But yeah, so you can kind of personalize it according to the user's risk profile. So now when signals exceed like a certain threshold, we have here like a controlled transition into something that we could call emergency mode with like stricter constraints. So emergency mode is not here to make any diagnosis or to replace any clinicians, but it kind of focuses a bit on a brief clarification, assessing here like intent, context, and like provide the validated resources or escalation pathways if necessary. So that means also when we have like a false alarm, like something like an emergency mode could be here to really assess if the subject is actually at risk, and if not, it could like de-escalate and go back to the normal conversational layer. So this design actually mirrors the principles from emergency call and crisis line research. So this is like non-abandonment. So we should always stay with the caller and not just like abruptly end the conversation. Then empathic clarification. So explore a bit more if there is actual intent, like check the severity and so on. Further then, of course, continuity. So stay with the caller or stay with the user. Sustain the trust. So inform them about the next steps that one is doing. And of course, also like subtle information gathering. So find out about the location, and especially like, for example, does the person have access to lethal means and details like that. So that means like when systems like this, when they are designed carefully, technically safe, and like with explicit escalation pathway, something very interesting happened. And this is also what they observed in Sonia, is that users often report trust, they show engagement, and something that would resemble what we call therapeutic alliance. And yeah, let's go directly into that topic very quickly. So up to now, we have talked about CVT mostly like in terms of the system behavior. So detection, escalation, and like what architectural constraints we should have. But like in digital mental health, trust is actually not only about what a system does, but it's also about how it relates to a person over time. And this is also where the concept of therapeutic alliance becomes unavoidable. So the literature here describes digital therapeutic alliance as the perceived collaborative relationship between a user and AI-driven therapeutic tools. So this includes goal alignment, task agreement, and some sort of like an emotional bond. Also, empirically, we can actually see that relational agents, they can actually achieve high engagement, high satisfaction, and like perceived alliance across different kind of populations. But, and this is like a very important point, like perceived alliance does not necessarily imply safety. So it is not equal to safety. So, and here also, while for human therapeutic alliance, the core pillars include like to foster trust, to communicate efficiently, and to also incorporate some sort of cultural sensitivity. Digital therapeutic alliance seems to work a bit different. So it seems to be primarily driven by design features such as like flexibility, interaction quality, or also like personal meaningfulness and so on. And it's not necessarily the therapeutic competence, which means that alliance can actually be very strong. So the digital therapeutic alliance can be very strong, even when the clinical reasoning is extremely weak. So that means while therapeutic alliance can be measured relatively easy, we should not or actually never use it as a safety metric. So if we go back now here at our tripartite approach, therapeutic alliance is something that just or that might just emerge on top of the rest. So whether we want it or not, in general, we want it, but it should not be a measure of safety. For this topic, there's also this book, amongst others, written by Toby. So I think we can even like have a nice discussion after that on that topic. So now, how to continue? So once we accept that therapeutic alliance can emerge in agentic systems, the next question here is also where things can actually go wrong. And here, this recent viewpoint described actually how sustained interaction with empathic chatbots could actually amplify delusional or also self-referential thinking in vulnerable individuals. So importantly, that means that harm does not necessarily arise because the AI is bad, but it kind of arises because it oversteps its role. So that means like it validates interpretations that it rather should question, or it mirrors belief that it should like more contextualize, or it provides meaning where uncertainty should be preserved, and most importantly, it behaves like a therapist without the therapeutic discipline. So how to avoid that or how to mitigate that is by using actually reflective prompts instead of like affirmations, to really do this reality testing and to have something like a governance framework for AI related psychiatric events, like even like in the pharmacovigilance style. And like the most important step, also like to have the escalation to human care if necessary. Because like in summary, like alliance without boundary is not necessarily therapeutic. It can actually really be unsafe. So, and here I just want to very briefly touch on sensitive data handling, because in agentic mental health systems, this is often treated as a compliance or infrastructure problem, but in practice, it's also like a clinical safety issue. So here also like recent work showed that while privacy preserving architectures are technically feasible, the users often misunderstand what actually happens to the data. So especially here in the conversational systems or AI systems. So when people disclose, for example, suicidal thoughts or delusional beliefs, consent retention and also secondary use becomes part of the therapeutic contract, whether we acknowledge it or not. So that means like if users assume confidentiality, but we design it for reuse, we kind of create a risk. So it's not necessarily a legal one, but also like a clinical risk. So in summary, or in reality, what we take away from today is that trust is messy, safety is probabilistic, alliance can be fragile, and boundaries are constantly negotiated, and data governance is somehow full of trade-offs. But how can we unify all these limitations into a safe framework for digital therapeutics? And this is here like my last slide, but also probably most important slide that summarizes a bit a framework for responsible implementation. And it starts here, of course, with the technical safety and transparency pillar, and which also goes with the explainability and the trustworthiness, as we have seen it in Trust LLM. But as mentioned, also we need to work with domain adapted clinical knowledge. So we really, depending also on the disease we want to work on or study, we should adapt the AI accordingly. So for example, a mental health chatbot has for sure not the same constraints like, for example, I don't know, like a diabetes chatbot. On the other side, again, like what is important is really like human oversight into the whole project of developing it, but also like evaluating it. So to summarize a bit, the step one, of course, is always to define the scope and the value. And here it's really like recommended also to work together with like stakeholders. That means like clinicians or like people with lived experience to like really find out what the product should do. And very early in the process, we should, of course, always get clear about the technical safety and the privacy setup to then further also have the domain adaptation. So as mentioned, we should really develop the guidelines and the clinical knowledge integration together with clinicians, and then accordingly also early enough think about the risk detection and like the different escalation pathways to do. Of course, before like using it on patients, like such a system should also always be validated and tested appropriately. As said, like not only on the technical level but also on the clinical level, so that then it can be like gradually deployed. So like first starting with like pilot studies and then so on and so on. Lastly, of course, as the field is moving very fast, there should be like also a continuous monitoring and learning so that whenever like models change or rules change, that like also the digital therapeutics change or adapt accordingly. Here also to keep in mind at all stages is of course the safety protocol layers. So here also we should really think of like multi-signal risk detection. So as mentioned, do not base risk detection just like on one single message, because for example, if a user talks about I just want to kill myself, but actually talks about like a difficult task at work that they just don't want to do, then of course an escalation here would be completely misplaced. Then of course further we have a graduated escalation pathway. So we should really like, we can implement like a first layer that is automated, but this should not be like the final layer. So we should really like have different escalation pathways. And here also most important one, if it's like really critical, always refer to clinicians. And of course, privacy and data governance, but this is like mostly predefined. So you just have to adhere to that. And here, like the key evaluation approaches are, of course, as mentioned, the tripartite evaluation approach. So really like, does it function technically with respect to clinical knowledge and also with respect to clinical reasoning? And always like include clinicians or experts to like validate whatever you have been working on. There's even like simulation-based testing, so you can even pretend to be a patient, try your digital therapeutic yourself, or you can even like make, I don't know, like avatars that test it before then also testing it on healthy controls and then eventually patients. But lastly, also to see how it translates into long-lasting effects or what are actually like the mediators of effectiveness. We, in the end, always will need randomized clinical trials. And here also like test the individual components, test against like therapy as usual. And yeah, so to actually then really find whether or not something is really effective. With this, I come to an end of this very dense webinar on the current state of the field. And as mentioned, I have this double affiliation with the Psychiatric Hospital and the Center for Digital Health Intervention. So from that side, thanks to everyone from both sides. And yeah, now happy to open the stage for questions and discussions.
Thank you so much, Samantha. Big applause here in person, not so much digital. That was very dense and wonderful, and I know how much time you had to prepare. I think that was a really fantastic overview. And I thought, when you came up with the question and what are the implications now for developing digital therapeutics, that this is the start for the discussion. But then you even came up with a suggestion and how to do it on your last slide. Yeah, exactly. So fantastic. Maybe I quickly start because I'm very impressed. And obviously the question is, I mean, you know, the tripartite framework, for example, was only recently published, or I think it was accepted. I don't know whether the actual paper is already published, but the wonderful thing you did. Oh no, Stephen. Stephen is here. Maybe Stephen should come first before I do my question here. I can also ask you
Please,
later.
please. I'll go ahead. I'll go second. If that's okay.
Okay, so you applied it to obviously your expertise, you know, the multicast project, etc. Can you quickly tell us whether it is good enough, whether it was useful to, you know, deal with this kind of topic?
In which sense do you mean that now? Like in
Because you present here a more advanced one, I think, you know, the
yeah.
one on that slide. But was it already useful in, you know, preparing this kind of talk? And would you recommend it also that everyone should read that one?
Yeah, I think the paper is actually very good, but as you said, it was just actually recently published. So like a lot of the preparatory work was kind of accidentally adhering to that approach. Um, but it's also like a lot of questions they came up and then we had to like go forward, go backwards. And that's why I think like having something that is like more like a stepwise approach, it really helps because like now when I look back, I think yeah, in the end we did a lot of the design based on that, but it was more by accident because we noticed like other things didn't work. Or that we, for example, we developed something, we tested it, and then we noticed, okay, it's not at all like aligning with clinical guidelines. So we had to go back talking to clinicians and so on. Um, so yeah, in the end, I think it really helps, yeah, because I think it's really necessary to have like really guidelines on or like an approach on how to like really start or where to start also, like what are the questions that you need to ask so that in the end you can really be sure that it's as safe as possible.
Okay, great, great. And now, very honored to have Stephen with us, please.
Yeah, so thanks, Tobias, and thanks, Samantha. I really enjoyed your talk. I had to jump in and out to various other commitments. So, I have a question actually that partly relates to the last slide and multi-signal risk detection. We've published a paper recently in Nature Human Behavior where we kind of propose, it may not be the first to propose it, so you never know in the modern world who's really the first to propose things, but um, patient or citizen person following risk detection rather than multi-signal within a chat interface. In other words, a kind of alternative way of thinking about things where the risk detection follows the person in their life, in their digital interactions, rather than follows their interaction within a tool. Now, this may be
Mhm.
complete nonsense, but I'd just be interested in your feedback on it. Part of the thinking on it, like I was very struck 2 days ago that Google announced the integration of Gmail with Gemini. So before, when I've got Gemini on my phone, and Gemini is not very cued into me. It doesn't really know that much about me. I could set probably, if I bothered, set certain preferences. But then suddenly a day passes, and I can get Gemini to answer my questions related on 20 years of my emails, including 100 gigabytes of information about me. And also 2 weeks before, I was kind of struck by Android integration with Gemini on my phone will offer to do a complete screen capture to answer my questions on the phone. So you kind of have this shift from large language models over a period of a few weeks from being isolated a few preferences to being highly, highly personalized, immersive. And part of our question goes along the side. If that's the direction of travels of large language models, having a personal chaperone large language model, which is actually a personal multi-signal risk detection, but follows you in your digital
Mm.
interactions rather than you have a separate multi-signal when you go to one tool, which may be Sonia, and then it doesn't knows nothing about all of the interactions you've had with other tools. You know, are you telling another tool that you're suicidal, but you're not telling this tool? What do you think of
Mm.
that, or does it have any merit?
I mean, my personal opinion here, I don't know if that's the correct English wording, but it's like this double-edged sword I think to some extent, like having like AI being like present almost everywhere, it can to some extent like really prevent, or it can really be used for prevention. So because I think like a lot of subjects, maybe before they actually go to seek for help because they are maybe scared of like being judged or of the stigma, it offers them like this anonymity that is maybe required for like early prevention. But on the other side, as you said, like, or as I also mentioned, it's like data privacy nowadays, it becomes a bit of a, it's not really easy to follow that anymore. And I think that's also where it becomes really dangerous, because every, or like almost nobody just reads the terms and conditions properly, and you just like, yeah, accept, whatever. And I think here it's like really, it starts to be critical, because maybe either some people, they don't actually want to disclose all of that. On the other side, it could really be helpful. Like, is it like for crisis detection, or just really like for daily business? And here I think it's really where like data privacy should be handled more carefully, in a way that also like users are better informed about like the risks and the benefits and everything. Yeah.
Thank you.
Right. Any other questions or comments?
I would also like to say, oh, sorry, just clicked in, sorry. Many thanks for this very interesting presentation. And I was just wondering about the Digital Therapeutic Alliance, and also the fact about sycophancy, or the model supporting or it being not being critical, and where is, yeah, exactly, if you go back, and that seems to me, it almost seems to be the biggest problems with the models now, and supporting people at risk. And I'm wondering how an app like Sonia, how can it be on the market on the US? Where was that approved, and how would you deal with that fact of sycophancy, where people are supported and not critically, and it doesn't allow critical reflection? How could we deal with that, or how could this be addressed, in your opinion?
Yeah, I mean, for Sonia, it's actually that's exactly what we just talked before. It's a bit this double-edged sword, because they are not approved as a medical device. They are like officially defined as a wellness product. And I think like this, you can easily be deployed in a market in the US. You just have to write a huge disclaimer what they did.
Okay.
And I think they're doing it pretty well. Like they really make sure that the users understand that Sonia is an AI chatbot. And on the other side, they also have like huge success stories of many like people that are using Sonia currently, that really report back to them like, this actually really helped me like a lot. And so yeah, I think it's here again, like as a user, you should be in a way like very aware of that this is an AI chatbot, which I agree could probably help also like in terms of self-reflection. But yeah, then very fast, if you maybe lack this kind of understanding or this self-reflection, it could actually become dangerous. Yeah.
Mhm.
Okay.
Thanks.
Maybe one last question for today, because we have only 2 more minutes officially, but it really gives me also the impression here. For sure, we will have follow-ups and then focus maybe more on the discussion and how to move forward. Especially, I just want to mention, we have also a lot of efforts this year to come up with the design and trial service for digital therapeutics, and obviously we want to implement technically also and help researchers in developing safe and effective agentic interventions. But with this, Ronan, I think you are now the one with the final question or comment here.
Oh, thank you very much. Yeah, my question went a bit in to the same direction as Sandra's, and it was answered in part. But yeah, I just wanted to comment that I really loved the presentation and all the concepts you presented, because it solves kind of questions I have in my own research projects. But at the same time, I'm also a bit frustrated because it looks so expensive to actually develop all of that. And then in the meantime, you have ChatGPT and the other big players who just go along. And I'm wondering if we can ever transition into a medical device setup, or if we always stay in the lifestyle app sector. So do you see a way forward to really apply this from a cost point of view in Switzerland, for example?
Yeah, but maybe as a comment in between, I think this is really the goal, at least, for the University Medicine Zurich with the Precious project, that we really try to focus on the very few but important building blocks to support research in the future, not to build all these assessments and validations from scratch, so that we can really provide already something to you, so that you can really focus on the delta for your population, and then be very efficient with that. I mean, that's at least the goal with Precious. But now, Samantha.
Yeah, I think in terms of cost, I don't know if I have like big opinion here. Of course, yeah, it's like a lot of work, which is costly. But I think to some or at some point we're also like in a very interesting phase right now, because like AI was moving so fast. It's currently still moving very fast, and like regulation is not fast enough, let's put it like that. And I think now we just really can like see and observe and like what actually happens, how will it be regulated. But I think as probably everything, at some point there will be rules on that. We know how to regulate it, and now it's just like this interesting phase on how we can see like how do we actually do that. Like we need to like find out what are the risks, or what are the benefits. And so on that terms, I mean, even if it's maybe right now annoying, I think we'll get there. But it's also like interesting to see how all this is handled and discussed. Yeah.
Okay. Well, that's it for today. Again, a big thanks to Samantha for preparing this wonderful input. And as mentioned before, we will invite you again. We keep you posted for sure on LinkedIn and our website. And we'll focus more on discussions and maybe dissect and discuss your proposal, Samantha, from the very last slide. With this, I wish you, as always, all the best of health. Stay healthy, do something for it, and then see you soon.
Thank you.